doctors get a bad rep for rushing their patients during their visits. But Dr. Wise talks about why that is and how medicine nowadays is not just about creating a treatment plan directly with the patient, but rather it includes managing their staff, processing the insurance paperwork, and reading medical studies to stay up to date. Hello, I am Faisal, and welcome to another episode of So What Do You Actually Do? This is a channel that is dedicated to students and employees help better understand their future roles. So if that is something that interests you, please stick around, subscribe, and like. Today, I got the chance to talk with Dr. Wise, who is a physician that specializes in sleep medicine. In this episode, Dr. Wise talks about why he chose the medical track, breaks down the specialty of sleep medicine, and mentions his daily interaction with insurance. Lastly, he mentions his salary and how physician or doctor salaries can range. Let's get to it. All right. Well, if you can give us a little bit of a background on your schooling, med school, residency, so on and so forth. Maybe also if you want to talk about why you chose this career.
All right, so um, let's track back when I was a kid. I have a lot of doctors in the family, and my uncle that I'm the closest to is a surgeon. Um, and my mom tells me this. I don't recollect it as much, but when he was studying for med school, I used to always hang out with him, and I was probably like 2 years, 3 years old. And so that's when the interest in medicine started. And he would always buy me toys that, you have the toy stethoscope or the doctor's kit, whatever, and I would play with it. So I think the interest built up pretty early on as I was a kid. And then when I went through school, biology was one of my favorite subjects in high school. Even though I was a little bit into coding as well, with technology nowadays, but biology always somehow hit the right spot. So when I finished high school, I had to make a decision. Is it medicine? Is it science? Is it commerce? And then obviously the decision was pretty easy, and I took the science route. I did my schooling in Saudi Arabia. That's where I grew up. And when it was time to go into medical school, I was exploring different options, and I ended up in India. One of the reasons why I took that course is because I didn't have to do 4 years pre-med, so I kind of saved those 4 years and just jumped right into medicine, which I knew was the route that I wanted to take. And so I did about 5.5, 6 years of medical school in India, and then I have a lot of family in America, and they built a lot of interest in me to like come and do residency here, exploring options that looked like a pretty good idea. And so I started preparing for the USMLE boards somewhere around fourth year medical school, and then took my boards, came down for residency, and ended up with family medicine in Illinois. Hospitalist and primary care was my primary focus early on, so I thought family medicine was a good pick because it gives you a whole broad spectrum of chronic conditions, hospital medicine, and you get to treat people all the way from being born until they're ready to pass on to the next journey. While doing so, sleep medicine jumped at me. A few patient cases that I experienced, I saw a lot of correlation between sleep medicine and chronic conditions, and I felt that having this extra add-on specialty would probably help me cater to the needs of today's population much better. And so I went to specialize in sleep medicine, which I did at Florida and Mayo Clinic, which was a really good experience, being one of the top schools in the US. And since then, I've been practicing sleep medicine along with a little bit of primary care, incorporating the associations sleep disorders have with chronic conditions.
That's really cool. But yeah, outside of this, it's always
Same
inspiring to
here.
have someone from within the family to trigger that interest in medicine, and create that pathway. And you found your way. I mean, it's such a global educational map if you think about it. You started somewhere, continued somewhere else, and then you finished somewhere else.
Yeah,
Um,
three different countries. Started in one country, ended up in third.
Yeah, yeah, that's amazing. And even within the same country, so you went for residency in Chicago and now you're practicing in Arizona. So that's a lot of west, east, north,
Correct.
south. Um, that's great. So
Exactly.
As a sleep physician, my understanding is you're in a clinical setup. The people are setting up appointments, you're addressing them, and then there's some sort of sleep center where they're having to uh, get analyzed. That they sleep at night, and the report comes out. Can you speak a little bit? I'm speaking very generically, but I would like for you to take on the details of what all is incorporated in sleep medicine.
All right. So just like as any specialty or any doctor's visit, it usually starts with a consult. There are a whole range of sleep disorders. The most common people are aware of is either insomnia or sleep apnea, but there's just so much sleep disorders that exist. So the first consult, when they come in, and no matter what they're sent in for, we kind of dive into every possible sleep disorder that is just to screen people. So that first consult can run from 35 to 60 minutes, depending on how much information we gather from the patient. And so that visit gives us an idea of what route to take. And there are so many different routes. Like you said, sleep centers, we do a lot of sleep studies. That's to kind of study somebody's sleep architecture. Do they have sleep apnea or not? Are we looking for movements in sleep? Are we looking for nightmares, sleepwalking, sleep talking, and all that? So that's one basic major aspect of sleep medicine is to do the sleep studies. But then, do we have to treat them with medicine? Do we have to prescribe medicine? Or do we work with other staff members? We have psychologists that we work with, there's neurologists we work with, there's cardiologists we work with, ENT physicians. So it just depends on what the requirement of the treatment is. And then so we can either do it ourselves as a specialist, or we incorporate help of other specialists to kind of cater to patients' needs. So the consult begins, the testing phase begins. Once we have a diagnosis, and the treatment part begins, which may be either one-on-one with the patient or with incorporating other specialties as well.
So, question on this actually that kind of just arose in my head in terms of patients. Are you seeing, as a sleep physician, compared, for instance, to other specialties, do you feel like you're seeing a lot of new patients compared to follow-ups, or is it a good blend of both follow-ups and new patients at all times?
Of course, when you start at a new practice, mostly what you see is new patients because you're building up your patient panel. On an average, now I've been in this clinic that I work with for about a year and a half. On average, I see 7 to 8 consults a day out of 18 patients. So I would say about a 50-50. And then I also have support staff. I work with PAs, I work with RTs. So if the follow-ups are taking too long to get in with me, or if I feel like somebody needs to follow up sooner, I usually use them as help so that we can kind of cut the wait time shorter. But on average, it's a good blend of new consoles and follow-ups.
Got it. And I think you just mentioned a key term, a key metric there, about 18 uh, patients a day, roughly.
Yeah, it again differs from practice to practice. Now, I worked in 3 different places before I ended up here. When I was training in my fellowship, I only saw like 7 patients a day because they were focusing more on quality care than quantity. When I was in Illinois, when I started working first, my first job as an attending, for sleep, I was seeing probably 6 patients in a half day, so not too much either. But this one it's a private practice, it's a busy clinic, it's a big establishment, so anywhere from 16 to 18 patients. And I think most places do on average 16 to 18 patients in private practice, but if you have your own practice or if you work for an academic institution, it might be less than that.
Okay, makes sense. So to unveil a little bit more on this, how much time is normally spent per patient, and what's your clock in, clock out time roughly every day?
I go in at about 8 in the morning and I'm done by 4:35, and 1 hour lunch break in between. For a new consult, it may take 30 to 45 minutes because that's the longest time you spend with the patient initially, gathering all the information. The follow-ups could be anywhere from 10 to 15, sometimes 20 minutes. So the follow-ups are not that bad unless there's complex care involved. But on average, those are the times I spend with patients direct.
Got it. So this is the part where outside of the specialty itself and that all the time and um, sweat and effort you put into the learning the trade, there are other things that are not necessarily taught, which is the paperwork, the insurance, the patient to doctor interaction that is outside of the treatment. Can you talk a little bit about those small details and how when do you address them throughout the day? So someone who's interested in this will have like a little bit of a holistic view of, okay, outside of being an MD in sleep medicine or DO in sleep medicine, what is it? What else does this come with? What other packages?
Yeah, so documentation, obviously they don't teach you a lot about it in med school or during training, but you do come across it as you go, and then you learn how to deal with it. A lot of the paperwork is directly with insurance. We put in for a test. I see a patient, I think this is what they should do. I put in for a test, or I prescribe a certain medicine that I think would benefit the patient better, and then the insurance will tell us, do they really need this? Kind of justify why they need this. Why should we pay for this? And then we have to kind of justify that why we chose this testing, why did we choose this medicine. And so that may take a little bit of time in between patient care. And most places are usually cognizant of that, and they give you academic time or they give you admin time. For me, like I work Monday through Thursday, full day, 8 to 5, but Fridays I get the whole day off basically. So I could rest so that I'm not feeling burned out, but I also get time to deal with these bureaucratic requirements, like paperwork, prior authorizations, signing on scripts, and things like that. Most of the things are streamlined, electronic, but there are some times when you have to, the old fashioned way, print out something, sign it, give it to your staff to fax it. And then it also depends on clinic to clinic how good of a support staff they have. Like for me, I have good people that work on these things, taking my notes, taking my information from either talking to me or my clinic notes or my passive notes about patients and all that. And they try to get things approved. If they need my help, if they say, hey, they need to talk to you directly or they need you to sign something, then it will come back to me. So that actually helps a lot and doesn't make you feel burnt out. But if you don't have that support staff, then you are required to do all that yourself, and then that may take more time. So if you are pursuing, things yourself and you feel you need more time, always I encourage people to talk about it, to bring it up to their administrative people that, hey, I need more time so that I can deal with these things and not feel burnt out or staying back after hours to be, able to catch up on things.
That makes sense. For sure. That is in any, I guess, discipline so far, we've spoken to a lot of people in tech engineering and business, but it applies in medicine. Most people have a perception that a physician is very well taken care of from a lot of different staff members that do everything for the physician. All the physician has to do is the touch and being there in the room with you. But I think if people haven't been to the doctor recently, they would have missed the some most of the time there's that rush of, all right, there it took forever to make that appointment. It takes not even 5-10 minutes to be addressed, but then there's the waiting time after. Well, all these things happen in the background, and that's why
Right.
physician feels the burnout. They're doing a lot of
Right.
things.
And you brought up a really good point. Sometimes people do feel, hey, I spent 10 minutes with my cardiologist. I had so many issues going on with my health. I felt unheard, or I felt like they didn't address everything. Most of the time, that's not true. We have years of experience. Now, I'll take an example: sleep apnea, right? So I have years of experience knowing what it is, being able to tell what it is just by looking at a patient, maybe hearing 2 minutes of them telling their complaints. I know what's going on. And so that short interaction the patient may feel is not just a short interaction, it's also experience that I've had for years, knowing that what's going on and knowing what to do. Unfortunately, when you're seeing 18, 20 patients a day, I would love to sit and chit chat for half an hour with everybody, but it's not realistic. I have to make sure that I'm addressing everybody. And sometimes I know that this is not a complex care. Even for the patient, it may feel it is, but for me, it's like I know this is what it is and I can address this quickly and efficiently, and the patient will obviously feel like they got help later on. But initially, yes, some people feel like they got rushed, but it's not. It's like the years of experience talking about a patient. And then from the time they see the doctor, all these things we talked about happen in the background. And then sometimes, like, I have to train my staff. I have to tell them, if you get this paper, we need to sign it this way. Or if we get this information from an insurance, we need to fill it this way. So there's training that also goes behind doors that I'm training my staff to be able to deliver care. And then I spoke to you about having PAs and respiratory therapists work with me. Again, we have hours of discussion behind doors. We discuss patient care after the fact that they've seen the other providers, or giving them expectations beforehand that this is how I like to provide care. So I would like you people to follow the same guidelines as I'm doing. So there's a lot more that goes behind doors that people are not aware of. And then, the care that you get is from a lot of experience, from a lot of hours we spend in making protocols and stuff, and also then taking care of the paperwork for you, so that you don't have to call the insurance company and say, hey, my doctor prescribed this medicine, can you please make sure it's approved? So we make sure all that is done for them.
Makes sense. That makes sense. That what you just mentioned in terms of years of experience to address a moment of time, to me, there's this very famous metaphor, people saying, you can fix the pipe yourself, but you'll pay someone to know exactly the point that's leaking, and or something along
Right.
the lines. And it's not necessarily a matter of pay in this metaphor that I'm trying to take out of. It's more of the identifying the issue. And when someone can identify it fast and efficient, I'm guessing in the sense that you're not wasting a lot of discovery work to find it. You're allowing that person to have least impact as much as possible. So it's kind
Right.
of it's a kind of an efficient world in a sense. But I guess
Mm-hmm.
this is coming myself being a patient. I guess the point there, and how I've felt from a lot of people being patients as well, is I feel like I am being rushed in and rushed out. But I can see, again, like to your point, there's a lot of behind the scenes that is going on, that if people understand that point, then they'll know where to either put their frustration or to be more understanding. And as to where the physician's time is going, there's so much that goes into it.
Correct. And like, I've been in both sides as well. I have been in doctors' offices. I have experienced how it feels to be rushed by other doctors, even though they know I'm a provider. I was at a cardiologist office years ago, and for me, that was a big thing because, when we go to a cardiologist, it's a big deal. You don't just end up at a cardiologist office just like that. And the cardiologist spent like 7 8 minutes with me, and he was like, okay, we're done, we'll follow up after the results. So I had some anxiety. So I kind of understand that when a patient comes in, that aspect exists. I make it a habit, and for the viewers and whoever tries to pursue medicine afterwards or is practicing and watching this, like, I make it a habit to at least ask patients twice, do you have any concerns or questions? This makes them feel heard. Even if you finish the visit in about 5 minutes and you have nothing to talk about, always ask them this at least a couple of times before they leave, so that they feel like the doctor was paying attention, or whatever questions I had were addressed, and I didn't need to like ask more. But if you don't do that and you're just like, okay, we're gonna order this test, come back and see me in a week, and you just rush out of the office, and the patient might think of something later on that, oh, I wanted to ask this, I did not. That shouldn't be the impression a patient leaves, because they're obviously coming with a lot of anxiety beforehand. They kind of trust you with their health, or sometimes with their lives, and so at least giving them that comfort before they leave makes a big difference.
Yeah, thank you for that. That is actually a great segue to where I wanted to go in terms of advice. That definitely is a great advice for someone pursuing medicine in general, to have that in mind. But what other advice would you have for someone who's interested in sleep medicine, whether that be a student in college who they are thinking of going into med school, and they're thinking of, what do I want to accomplish by the time I'm done? What specialties I'm thinking of? And you can talk a little bit about this specialty you're in. What advice would you have for them?
Sure. So for me, I think sleep medicine was the best thing that happened to me. A lot of people, when they think about sleep medicine, either they're not aware of what it is, or they think, oh, it's just sleep apnea. But it's not. It's a whole lot of medicine that goes into it. You know, there's so many disorders that's about sleep. So if somebody's interested in learning, in exploring and doing more research, this is like the best field because it's such a growing field. It's newer. There's a whole lot we're discovering about treatment options for different sleep disorders. And every year, new research comes on how sleep is associated with other specialties. Before, everybody thought, okay, sleep is just, you know, you're sleeping good, you're not sleeping good, we treat that and it's done. But no, then we came to find out that a lot of heart conditions are associated with sleep disorders. The big one is atrial fibrillation, high blood pressure, heart attacks, heart failure. Then we found out that a lot of sleep disorders are associated with neurology, so dementias, Parkinson's, you know, memory issues. Now we're learning that it may be associated with respiratory disorders or with blood disorders or kidney issues. And not just that sleep disorders lead to these conditions, but other conditions may lead to, you know, sleep disorders. Like if you had a stroke, if you had kidney problems, if you have heart failure, you can have sleep breathing disorders that are kind of different from obstructive sleep apnea. So there's so much correlation. So it's not just that you're doing sleep, but you're also doing medicine in an innovative way. You're helping other specialties, you're interacting with other specialties, and then you're at the forefront to bring in more to the literature of sleep medicine. Now, I have written a sleep chapter myself, which I think was a big deal because, you know, I'm contributing to the literature of sleep medicine as we go along. I get to write about case studies that nobody ever, you know, saw before. So they get to learn from my experiences, and then that may become like 5, 10 years down the line, may become a part of a protocol or something. So there's just so much scope of like being there as a first author or as a first person who discovered something in this field. Then there's so much association with different specialties. And then people sleep 1/3 of their life, you know, 7 to 8 hours a day is 1/3 of your day, and 1/3 of your life you spend sleeping. So it's a big deal for a lot of people if they're not sleeping well, if they're not feeling rested the next morning. It impacts the majority of their life. It impacts how they behave with other people, how much they're able to socialize with other people, how much productive they are at their work or their school. And so by helping them, you are bringing a lot of change, a lot of improvement in somebody's life, and that's a big impact. So I think the specialty hits the nail from a lot of aspects as a difference you can bring into the medical community as an individual themselves, and the satisfaction you get from being able to do that. And then it's one of those specialties where you don't have to stay after hours for, you know, on being on call or working nights. You get to have a good social life, you get to have a good family life, you're not burnt out as much. You know, I love to travel, so I travel pretty much every month. You know, you don't get to do that with most jobs or specialties. I get to spend time with family. I get to, like, you know, spend time with friends as much as I want. So I never feel like I'm going to work. I feel like I'm going to do something I love, and then I come back and do something more that I enjoy afterwards.
That's amazing. That really sums both the professional and the private aspect of it. So thank you for speaking to it.
Of course.
And for sure, the 1/3 part of it, I think a lot of people, especially in modern day, they're just so consumed that they only realize 1/3 of their life is spent in sleep. And it is important to lock that number in is when they hit a wall and then they come
Mhm.
to see you. And then they're like, oh,
Yeah.
I forgot I'm human. It's important. Um,
And even subconsciously, you know, with all the technology that's coming up, sleep is being pushed into people's minds. Now, if you have an Apple Watch or a Fitbit or a Samsung Watch, whatever, they give you metrics about sleep. So somebody, you know, scrolls through their metrics one day and they're like, oh, I'm not sleeping well. I'm waking up a whole lot at nighttime. Why am I not getting enough REM sleep? Why am I not getting enough deep sleep? Then that starts to become, you know, a part of like their concern as well. So even subconsciously, technology is pushing sleep as a major aspect of health. And I think in the next 5 to 10 years, there's going to be a lot more push that every specialty is going to be to address sleep issues as a first step in managing their chronic conditions.
I appreciate that insight. And the last question I have for you is, what is a typical salary range for a physician in sleep medicine?
And so that can vary a lot depending on, again, where you're practicing. If you like teaching, academic institutions usually pay low, but there's more satisfaction because you're trying to, make a difference by teaching residents, by researching and things like that. If you work in a private practice, the pay is more. The pay also depends on how many patients you're seeing, how much productivity you're bringing in. So from my experience and getting job offers and all that, I can say that I have seen ranges from 200,000 up to $450,000. The 450 is probably an outlier. You don't usually get that much, but I have seen offers up to that. Most of the time, in a good city, in a good institute, you can kind of expect between 250 to 350, 100,000.
Got it. And that is within the same 8 to 5, no um, crazy hours on weekends and continuous weeks of work.
Correct, correct. So for a typical sleep doctor, it's usually the same structure. It's outpatient mostly. If you work in an academic institution, you may get some consults inpatient, but that doesn't mean that you have to round on patients the whole day. You may get a consult here and there. You go see the patient, you're done in about 20, 30 minutes. But typically it's between 8 to 5. Some places even do just half days, and they give you half day time to read studies and work on admin stuff and all that. But typically it's 8 to 5 outpatient, no call, no nights, no weekends.
Got it. Got it. Thank you. Thank you for describing that. And do you mind if I call you Dr. Snooze?
Go ahead. Yeah, that's my handle on social media. That's a brand I'm trying to build. And so it's funny. My car's license plate says snooze, so it's like my snooze mobile too.
So I wanted to keep that until the end. And that is true. Your Instagram handle is Dr. Snooze. And every time I was thinking of you and setting up interviews, and even my notes says Dr. Snooze. So now you're officially, whenever I snooze, I think of Dr. Snooze. Um, Thank you for this time that you've shared with us. I hope people that are interested in this discipline with our students in high school or college, all across the world, thinking of medical school and what to do after that. Here is something that you can think of, or people that are in medical school thinking of what do I want to pursue for residency? How can I be on the forefront of literature and information that is still upcoming, and it's going to be shaping the world, as you've mentioned, in protocol and different categories. It is something to really consider. At least to summarize, 1/3 of your life is spent in something that can be your discipline too. So
Exactly.
without further ado, I'd like to snooze this episode and put it to rest.
All right. Thank you for having me. Thank you for having me.
Appreciate it.